Remember, the sooner we start, you know where I'm going with this, right? That's 1 month. One track line right now. My stomach is broken. No cookies. It looks like the first motion that we have is the motion to adjourn. No, just seeing if anyone's paying attention.
I'll make the motion.
Okay, thank you so much. Do we review and approve the October minutes already then?
No, we didn't.
Okay, motion to approve the minutes from October 2nd. If there is seconds, please. All those in favor? Yay. All right, one down. So next are the correspondence and the DOH disciplinary actions. These are two motions on the table here. One from the DOH notification that the town of Lexington Fire Company has surrendered their ambulance operating certificate and has become a BLS first responder agency. And you want to take one at a time?
Yes.
On the table. And then the second, also from the DOH, is the notification of statement of deficiencies from the Berlin Volunteer Fire Company ambulance for not responding to 911 calls. And to note that Berlin will cease operations and transfer their operating certificate to Grafton in the near future. Any questions, comments, concerns? Now on to committee reports. Academic.
So, two new members, Jonathan Barons has been voted in. Stanley Lukaki has also been voted in. There was discussion on adding dual NEBs to the hospital Pyxis. Currently, at least at St. Peter's, it's not. Mike mentioned he believes maybe one of the other St. Peter's hospitals has it. I don't know, Sam, if you know. It was brought to me by one of the clinical pharmacists said, why are we giving Atrovent and albuterol out, but we don't have dual NEBs? So we looked in the protocols. The protocol actually is there, and it's in the formulary, so we can add dual NEBs to the Pyxis. So the next step is, I guess it needs to go to the nurses committee to approve it, and if that's the case, then we'll add it to the Pyxis.
Don, is BLS just albuterol only though, not Atrovent?
Yes.
So that's the part that might hurt us.
Right.
I'd
Well,
love BLS to have Atrovent
They
too.
still, well, also if you're worried about kids, you may not want to give them Atrovent, depending on how young the child is. But so we'd still end up giving albuterol.
So you can use both, okay.
There is a side issue to this discussion, which probably isn't appropriate here, but I know in our system, Trinity is pushing for respiratory therapists to be the arbiter of medication administration for nebulization. And they want all respiratory therapists to actually be giving the nebulizers as opposed to our ED staff. Obviously, there will be an exception to people who are in extremis that we need to administer that medication ourselves. We can't wait for respiratory therapists to come to the ED if they're not already there. But I just mentioned that as an aside, because that medication has to be in our Pyxis and has to be available to ED staff.
Yeah, this would be the Pyxis for EMS, basically. So they would be able to pick up dual NEB and they wouldn't bother having to mix it out.
I don't see why that's an issue.
There's a bit of a discussion on future protocol rollouts, which will be much more organized than what happened this year. We'll go into that detail. Mike gave a good presentation on leaving the naloxone program, which I believe is later also in this meeting. Do that again, correct?
We can.
I think it was in there as one of the other things. And there are a couple of EMT original courses out there. The main issue from a vote standpoint is the state's decreased the CME requirement to 60 CME per 3 years. So, and Dean, I'll have Dean read his long proposal that was approved.
change the REMO CME requirements to be 1/3 New York State CME requirements for those who are enrolled in the state CME recertification program. Other providers will be required, other providers will remain at 24 hours.
Would you reread the first statement, please, Dean?
To change the REMO CME requirements to be 1/3 of the New York State CME requirements for those who are enrolled in the state CME recertification program. 1/3 of the hours, yes.
In other words, that's reflecting 60 hours over 3 years, but not specifically saying. The state requires 60, so it'll be 20, 20, and 20. And rather than saying 20, 20, and 20, in case they decide to change it again to, let's say, 45, then we wouldn't have to change that.
Right.
Motion again, then it would be 15, 15, and 50.
I just want to make sure we're not asking people to do only 1/3 of the CME that's required of them.
No.
That's why I'm just trying to get my head around what the proposal is, that's all.
Put in the word annual and then put in the 3-year requirement.
There you go.
On the state part.
There you go.
Right.
That makes more sense.
Yeah.
What if they move it to
Annually, yeah.
a 2-year or a 4-year recert though?
They'll have to revisit that.
Okay.
That'll be quite a quarter and quarter. Other than that, yeah, business still good, I think. I guess there's a instructors update and AHA instructors update at Hudson Valley, January 17th. That's basically it. After that.
Thank you. Ramsco? Takers? CMAC?
There's no meetings for
No
CMAC or
meeting.
SEMSCO.
Let's go.
Till January.
July?
Jeff, anything else for you this July night?
No, it's not.
Just-
It's not it.
Okay.
It's the other thing.
Oh, okay, I'm
That
sorry.
other guy.
Moving right along, and now for agency updates and upgrades. CPAP for Stanford Heights Fire Department. And the BLS 12 lead Waynesburg Volunteer Ambulance. For ALS upgrades, there were none. For BLS first responder upgrades, none. And for EPCRs, there were none.
Heidi, if I may, the Dwaynesburg Ambulance 12 lead program, this is going to be our first BLS 12 lead program in the region. They are required through that program to make sure that every single 12 lead that they do is reviewed by a physician. So for the folks at Ellis, they may get additional calls, they may get additional transmitted 12 leads. That's just to make sure that we maintain the safety of the system. There is nothing in the BLS 12 lead program that teaches basic life support providers to interpret 12 lead electrocardiograms. This is the process of acquiring and then transmitting that EKG. The goal being earlier recognition. Thank you.
For public access defibrillation, all PAD apps were reviewed by QI coordinator and in proper order. From GE Power Schenectady Original, Wildwood School and Program, 10 updates. Express Scripts Troy Original, the U.S. Department of Housing and Urban Development update, and the Highland Tank of New York update as well. For new business, now we've just had our stroke update. And Dr. Daly, would you like to continue on with the Leave Behind naloxone program?
Sure. So I have a copy of a draft advisory that has subsequently been updated, printed out here just for any of the docs that want to see this. But what we're going to be implementing is a Leave Behind naloxone program, which basically is moving the community access naloxone programs that are going on through some of our emergency departments and at needle exchanges and other harm reduction venues so that community members can have naloxone to use in cases of overdose. It's moving it right to the tip of the spear. So if EMS finds somebody with opioid use disorder, they believe there will be benefit from having naloxone there, EMS will then have the opportunity to do some just-in-time training for the people there and leave naloxone to help somebody in case of the next overdose. The first thing that we stress in that training is to call 911, and most importantly for all of the shekel counters at the agencies, there is no cost to the agency. The Department of Health AIDS Institute and the Office of Drug User Health is an enthusiastic proponent and supporter of this, and this program is basically going live now with the help of Anand down in Columbia County. So, any questions?
How about the IV nitro program?
Cool. What?
How about the IV nitro program?
From one into the other. IV nitro is being done at several agencies. Gilderland's doing it, Clifton Park is doing it, Colony is doing it, Malaysia, I believe, is about to start. This has been done incredibly successfully so far. We have about 18 cases across the region that I've identified at this point, all with fantastic results. My suggestion would be that we make this a little bit more available to folks throughout the region. The one thing we are still waiting on, and I have not gotten any confirmation, we did put in a formal regional request for a waiver for the 250 ml vial.
That would be Mr. Clayton.
Well, so I've sent the waiver request, went in months ago directly to the director, and I have still heard nothing. You suggest I go direct to Dan?
A lot of that is being gone through Dan and Steve. I'll ask for you.
Please ask, because what we will do otherwise is we'll use a smaller vial, inject it into a 250 ml bag of saline, and then use that bag of saline to draw the drug out of using a syringe. What we are creating with that is several opportunities for potential drug misadministration, specifically because of an outdated and inappropriate addition within Part 800 that has no purpose other than, right now, to create harm for patients.
I understand, but you also are very well aware that they're reviewing all of Part 800 to revamp it.
The process of reviewing a regulation, particularly a regulation that has multiple waivers already issued from it, should not delay a regional request for waiver, right?
I will pass
You don't
it
have
on.
to answer that.
I will pass it on.
So, we will continue to ask for the waiver. Hopefully the waiver will appear. Under no circumstances is that 250 bag ever to get IV tubing put into it. And we have to be very, very careful of that. I'm worried about drug misadministration. We have to be very careful. So, the safest way for us to do this is very clearly with the 250 ml vial of premix. So I think we have enough information with this so far, Don, to bring this to CMAC. If it's all right with you, let's do that and bring it in January.
And you want that as a protocol change?
No, it's not a protocol change. It's just a notification of a successful program that is within the existing protocols.
I think nitro was, if I recall, that was one of the options.
Right.
Okay, no problem. Either.
We should probably put it on the next med standards call.
Yeah.
Thank you.
Psych issues?
That's it.
Psych issues?
I think that's the next job.
Psych issues. Back to me again, Steve, sorry. I'm actually a little bit concerned as to how big I am on this screen today. I'm too close to the camera. Psych issues, just so you guys know, we had the director of the Office of Mental Health for Albany County here at our last meeting. That was fantastic. Since then, there have been meetings between St. Peter's and Albany Med with the Office of Mental Health and the Albany County Department of Mental Health to continue to discuss the situation of multiple patients and no places to put them. Those discussions are ongoing. The Office of Mental Health is actually going direct with both St. Peter's Health Partners and with Albany Med. And they're continuing to explore other alternatives for taking care of psych patients. And it'll just be all of us being as creative as possible, working to take care of a difficult group of people as safely as possible, both for us and for them. So stand by and be patient with us, please.
Well, I don't see Deb here for her report, so back to you.
She's in there. Deb just walked by.
I'm good, just in time.
She's not heading this way.
Want to give us any feedback in the meantime?
So, STEMI update, this is for St. Peter's and for Ellis more than anybody else. When we started the Mission Lifeline program for STEMI systems, one of the things that this organization pushed forward was the requirement for hospitals that are doing percutaneous angioplasty for heart attack patients would give feedback to EMS on every single patient that received, that went direct to the cath lab from EMS. That has fallen off, and this is just me encouraging people to please work with your cardiology groups, work within the systems of care in the hospitals, and please work to resurrect that feedback for EMS so we can continue to succeed with that. Thank you. Come on in.
I'm in.
CARES update?
Over the threshold.
Do you have a CARES update or no?
I do.
You do? Awesome. Give us a CARES update, please.
All right, so end of year report on CARES. We actually have 5 counties up and running. We added Columbia County. I need to talk with you about whether we'll enter 2019. There's reasons to and there's reasons not to, but we can. If we decide to, there's a potential 134 calls for Columbia County to be entered. I'll be taking donations to my fund for sanity purposes if I have to enter all of those. In any case, Rensselaer County is our last. Just taking a quick look for how large that is, there would have been 272 calls for 2019 if we had been entering those. All the rest of the counties are functional, and so that is CARES. There will be a 2019 annual report that will come out, I believe, the end of February or beginning of March 2020, including all of our data, probably with the exception of Columbia County. It'll have the 4 counties that are currently running in it. And I will bring that to the committee at that time. That'll be an annual report comparing within our area and also comparing to us to national results. Let's see, there was one other thing, I'm sorry, I didn't, oh, protocol exam. I know that you've talked about protocol update, you've talked about the changeover in CME and such. The other thing that kind of ties into that is the protocol exam. Several of my committee members from the first go-round of providing questions have provided questions to me. There's a couple of other people that I believe will be doing so, and the new exam will be ready to go on January 1st. That will reflect current protocol and all of the state and collaborative protocol changes.
Awesome. Thank you.
Okay, thank you.
I think the camera's fine on Dr. Daly. Next on that would be the February agenda item for trauma reps, reports, discussions. Not hearing any. Moving on to any old business. You guys are on a roll. Any other items from the floor? Well, I I would like to thank everybody for allowing me to serve you today in the interim. And I'd like to wish everyone a happy holiday and a wonderful season, and enjoy your loved ones. And do I hear a motion for adjournment? Well, now everybody's awake, sure. All right, thank you everyone very